come from discussion together and argument. So I'm really going to, we're hoping to do what we have done elsewhere, and that is kind of bounce off each other and have serious arguments, which sometimes evolve. So, yeah, let's go. This represents part of South Africa, which is very interesting. It's where, it's in St. Lucia, and it's a protected area. With a unique flora and fauna. It's where the river meets the sea, and there's been a lot of a sort of conservation focused on studying this area and its particular life form. And basically I'm just using this as a metaphor to say that where cultures interface, where languages interface, a lot of interesting things happen. And that has been the focus of my research over the last several years, trying to understand the particular life forms and the particular opportunities, trying to identify facilitators to the whole process as well as barriers. So that's what we're going to be talking about today, is some evidence emerging from some of our research, which I'm hoping at this stage to be able to put into some practical advice and suggestions. So we're going to whiz through some of the talk, and I'll be open to any interactions or discussions because it's a small enough group to be able to do this. So this is a map of South Africa that we don't see very often, but it's actually a language map of South Africa. And in some way it represents the huge linguistic diversity that one encounters in that setting. There are, in the new constitution, 11 official languages, but the reality is very different from that. Up to 80 languages, for example, being spoken in one healthcare setting that we audited in just one week when we did that, because of the migration, because of the porous borders, and just because it is such an interesting place to be. So this is results from the census, reflecting the relative proportion of the population speaking these official languages, which I don't really trust or believe because of problems in census collection and how one defines what one's using in as far as language goes, because of course every person in South Africa is at least bilingual, but more commonly trilingual, multilingual, and it's very, very often the case that in a healthcare interaction, both participants, both the doctor and the patient, are talking in a second or third language and not in first language of either of the interactors. So it's kind of interesting what goes on there. And one of the models that I am promoting is this kind of multilingual model. I don't care what language anybody's speaking as long as they're being mutually understood. And sometimes that happens. There's a wonderful situation where, I say to somebody, look, I don't speak your language very well, but I understand a bit. Do you mind if I speak English and you speak your language? When we don't mix, let's negotiate, or let's pull in somebody else. So it's kind of an interesting game to play. My health communication research unit has been looking in a number of different domains, but we've been focusing a lot on HIV/AIDS because of the pressing need of communication in that area. In various different sites, using various different languages. We've been working in the Western Cape. We've worked in Xhosa, Zulu, we've worked in Tswana, we've worked in Shangaan, and we've worked in some of those domains. I'm going to focus a bit today on HIV/AIDS and pharmacy. We've also done some work on respiratory disease, sometimes in urban settings, in tertiary and secondary hospitals, and often in rural settings. So I'm going to share a bit of this data and talk about what we've been doing. Our methods have been primarily qualitative, drawing on methods from anthropology, sociology, simply because the kind of challenges seem to be best answered by using some of those qualitative techniques. So typically we are approached by a site, or we're asked to go in and look at a setting and kind of see what's going on there. We record, often video, sometimes audio, using methods like ethnography. We also do focus groups, interviews, narratives. We have a range of qualitative methods, and then we translate, transcribe, and subject it to various types of different analysis depending on the questions that we're asking. The critical component, and I think this is where the social activism comes in, is that don't leave it there. It's important to take what we've found, how we've analyzed the stuff, and feed it back into the sites to see if it works. And that's what I'm going to talk to you a little bit about today, because how do you prove effectiveness? In the one site that I was working, we did a fantastic intervention. Then there was a flood, then some of the staff left, there was a strike, etc. So things were different the following year. How could we attribute it to our intervention and not to some of the other societal and political factors that were happening in the context? So that's hard to show that things work. Okay. Of course, it's not just language differences that cause problems in communication in South Africa, or indeed in any country. It's political and social factors, and South Africa's complex political history is also going to contribute to a lack of understanding, particularly in a healthcare situation which is characteristically asymmetrical. So these are things that we have to sort of bear in mind, and I firmly believe that medical students need to have courses in anthropology and politics as well as in philosophy, but that's another story. Okay. This is a map with which you're all familiar, just reminding us about the burden of disease and the demographic profile of the disease, which is very interesting because it actually provides a motivation for looking at some of the difficulties in management of HIV/AIDS using a slightly different lens from the typical. It's significantly changed our practices. It's really made us think about issues like adherence. While ARVs are now widely available, there still remains issues that a lot of patients are not taking their drugs. There are still huge issues that can be identified in any context around disclosure, about stigma, and we really believe that communication may be the key, the answer to the solution to some of these issues. Some new features of our society are also very challenging in terms of communication issues, research ethics, and these are just some of those. Child-headed households, orphans and vulnerable children as potential participants, the resurgence of other diseases such as TB and so on. These are things that you all know. With regard to the disease itself, we know a lot of things. Science has helped us understand a whole lot about disease progression, about risk factors, about prevention strategies, about ARVs. And I just heard, I think I heard last week or 2 weeks ago, that there's now a single dosage ARV once a day that you can take instead of the new drug regimens, which is being rolled out in a very gradual way. And that's interesting to me, who they've chosen and how they're doing it, but that's another story. So we understand these things well, but there are things that we still have to understand better, and that's why prevention programs don't work very well, why patients continue not to take their drugs. We don't understand the impact of things like poverty, literacy, discrimination, migration, etc. We don't understand why many people are still very, very highly suspicious of ARVs. We don't understand the impact of other generations, like what grandmothers say, for example, is the cause of HIV, how that impacts on maybe a granddaughter not taking medicine. So there are a lot of things we don't understand well. And it's because it's to do with the human factor. Okay, so we really need to understand better some of the behavioral background to these challenges. And this is a slide kindly lent to me by Mitch Besser, who sort of shows how behavioral modification in Uganda links to the prevalence of HIV. So there's a very, very strong case for saying we need to be interested in what behaviors and how behaviors are going to influence this pandemic. So let's have a look at the issue of adherence. What I'm going to do is I'll pass around this little book, which was kind of one of those products that emerged from some of our research, which we're quite proud of. It's a little book about, for pharmacists, working in Africa, which was distributed through the partner network. I'll tell you a bit about that in a minute. But so while I talk about some of our pharmacy research, you can have a look at how we try to turn research into practice. So the literature and our research suggests that there are a number of factors influencing, for example, antiretroviral adherence in the clinic, and indeed adherence to probably most drugs. But what we did is try to look particularly at whether communication factors were amongst those barriers to care. And here's a really nice quote that highlights our goals. Okay, the most promising area for improving medicine-taking behaviors is that of counseling and enhanced communication. So we take that challenge and we try to prove that that does indeed follow. Here is an article that we put together, data from 4 different sites, into a kind of a review article. There was a special edition in this patient education and counseling. The whole edition was on pharmacy for those of you who are interested, because this was quite fun to do. Okay, so these are the 4 sites that we merged the qualitative data from those 4 sites, and that's a horrible job to do. Those of you who do qualitative analysis, so much easier to do quantitative, and don't ever be fooled into thinking the opposite. Okay, so the one, as you can probably recognize, was a large hospital in Cape Town, a pediatric HIV clinic. We also did a pediatric HIV in another in Gauteng, and we did one in an urban provincial hospital, and then in a very rural setting. So we combined some of the data. And I'm not going to go into methodological details, but in general, this is what we managed to combine in this study: 34 patient and 40 caregiver narrative interviews, using either individual interviews or focus groups, and 49 healthcare worker interviews or focus groups, combined with ethnographic observations. And of course, ethnographic observation takes a while. You have to be a fly on the wall for more than a day. You have to kind of be around and hang around and get used to the systems and kind of just, I don't know, be there. And then we subjected it to various levels of analysis, thematic content analysis primarily, and then looking particularly on facilitators and barriers to adherence. A note on ethics. Yeah, a note on ethics. Probably focus group ethics being a big challenge, because there are limits to confidentiality in focus groups, and this is something that's important, and something that maybe sometimes restricts what one's getting, but you really need to put out front the limits to confidentiality, particularly in HIV/AIDS context. So 3 major themes are dealt with in this article, and these are some of them, and I'm just going to illustrate them, that these things seem to be particularly important: communication and relationship variables, factors around the actual illness and the drugs and the treatment, and then what we call Lifeworld, to use an English term, and cultural variables. And I suppose this diagram is trying to illustrate the interface and the interaction between them. What was interesting, we were trying to get the patient's voice and the healthcare provider's voices, and to see whether the same barriers and facilitators were identified by both groups of people. Sometimes they were, sometimes they weren't, and that's the interesting thing. I mean, the literature will tell us about the barriers all the time, but we need to differentiate the voices and to understand when there's discord. So I'm just going to illustrate some of these issues. And here these tables are very, very simplified for those of you who want more, go to the article, but let's look at, under communication theme, for example, what patients, healthcare providers, and our own observations identified as being facilitators and barriers. Okay, and we've got some quite a good examples. So there is correlation, but there's also sometimes a mismatch, and that for us is interesting. So let's have a look at that. The patient says, it really helps to have a good relationship. It really helps to understand the notion of CD4 count and viral load. Okay, and equally, language barriers were cited as huge issues for the patients in preventing regular taking of drugs, not understanding those things. And you can see the healthcare provider's perspective, and where, our observation of where there was a good cultural broker, a third party in the setting, of how that actually helps to facilitate issues of adherence. So those things are discussed. Let's give you some quotes. The doctor came and asked, how do you feel? Not why did you escape from the other hospital? Okay. So here's an example of the patients telling us things that we need to put back into the system. And my experience, and it's been a very humbling experience in all the sites that I've worked with and the hundreds of patient interviews that I've done, patients are fantastic consumers of service. They know exactly what's going on. I've sat in a clinic where there were 2 doctors, and all the patients move their chairs to the one line outside one doctor's office. They're happy to wait until 7 p.m. at night for this doctor rather than that doctor. These are patients often without education and literacy, but they are making judgments based on the kind of judgments that we're making with detailed video analysis of non-verbals and verbals and everything, and after 5 years we can say, oh yeah, this is a good doctor because he's doing this. They can do that in 1 second. Neil, do you want to say something about that?
Yeah, I think to some extent it's true. I had a long conversation with a fellow named Joseph Buzalisi in Durban. He's a fellow who's also happens to be the janitor in my mother-in-law's apartment complex, and also the head man in his village, and my resource. And he said to me, when I'm with one particular doctor, and only one, I like him a lot. And I said, well, why? He said, I feel like he and I are singing the same song. And it was just, that's what Claire was talking about. The other doctors, he wasn't quite so sure. So
yeah.
Another metaphor.
So here's a patient perspective, and then listen to this distressing contrast. I just give my child all these tablets without knowing the reasons. I will probably end up giving him all the tablets we come across, because even the ones that I have, I don't know what they're for. I just want my child to get better. I don't want this HIV and TB because I don't know how he got it. So kind of a despairing, uninformed perspective, and a bewilderment, an overriding bewilderment.
Claire, excuse me, can we go back to the second quote, which is really alarming to me? I want to hear a little bit more about a doctor who would tell a patient that they're HIV positive when they're not. Is that what that is?
No, no.
What is it?
No.
No. This is not. The mother says that she understands that her child has
No, this quote.
The second quote, in green.
Green.
Oh, the second one, okay. Oh, yeah.
That's a doctor telling
Oh, no, this is probably a counsellor.
a counselor,
Yeah.
but still.
I've seen that. This notion of disclosure, they're trying to kind of align with the patient, trying to make them understand, so sometimes they actually do that. Yeah, sorry, I didn't read that bit. Yeah. Yeah, that is interesting. And our counsellors often actually do that to try and get on the patient's side. They say, yeah, we know it's very difficult. Like when I take my medication, I've seen counsellors reach into their bags and, kind of share the pill bottles with them to kind of get patients. The healthcare providers are sometimes desperate. The pharmacists, when we did our pharmacist study, I have never seen such high energy, such multiple efforts to get adherence going. And the pharmacy study is particularly interesting because pharmacy comes at the end of the day. Patients have had bloods and vitals, and they've done everything else. They've seen the doctor, they've waited in long lines and everything, and then you're shoved off to the pharmacy. That's your last port of call. And the pharmacists feel that pressure. We're the last guys who have to get the message right for these patients before they take their drugs. And sometimes drugs for 3 or 4 months, depending on the clinic and the site and everything. And we're the ones who are going to save the patient's life. So the efforts to which pharmacists sometimes go, and I have seen this strategy. It is alarming, isn't it?
Yeah.
I don't think it's uncommon in the U.S., not so much to say you have HIV, but you have allergies or you have kids that have been in trouble with the law or other things. Again, to help identify with the patient that you feel their pain, so maybe they'll do as you say.
But to say things that aren't true as well.
Isn't there an ethical issue with that? I mean, because if that patient discovers later on the that healthcare provider was lying, wouldn't that implicate them how they can go forward together?
I guess that's one of the trade-offs people make, trying to be effective versus, no different than some of the things maybe people have told their mother. If she doesn't catch me, then we're okay. I'm not saying it's good or bad. I'm just saying it happens.
Wow. Okay.
Okay, so these are some of the facilitators and barriers, and I'm not going to go through all of them because we've got limited time. But generic packaging has been ghastly. The government rollout that you have to take these 3 pills, and this month it's in a yellow packet and a green packet and a blue packet. Next month it's something completely different. Again, when you've got patients who lack literacy, lack education, they're very, very confused. So we need to develop strategies to kind of handle these issues. So these are some of the things identified on both sides under this theme. I was so scared, I didn't even know if my child will survive this, but now I'm happy because I can see she's doing well and she's drinking the medication, and the CD4 is going up, viral load is down. I'm happy about this clinic. We love things like that, okay? From the first time I started taking my medication, I started getting dizzy. It felt like I was drunk. So, patients are able to describe the side effects and reasons perhaps for poor adherence or reasons for things like that. So these quotes are kind of very helpful because if you can use, and these are translated obviously from the original language into the English, but sometimes the terminology that is used is very, very helpful to maintain. So even if an interaction is taking place in English, to use the specific terminology that patients are using is very, very helpful in a bilingual kind of way. And then, there are many of the barriers identified from the Lifeworld related to traditional healing, stigma, loss to follow-up, and these kind of things which you're all familiar with. So it's nothing, the study is nothing new. It was just coalescing data from 4 sites and trying to look at it in a kind of a new way. My boyfriend says it's a myth. There's no HIV. Okay? The traditional healers and faith healers damage ARV adherence, especially if patients are trying to use their own concoctions. They sometimes get controversial or mixed messages. And that is very, very, very true. How to ask these things is sometimes hard because of previous experiences at a clinic. So a doctor who's trying to sort of say, what else have you done? How else have you done it? Sometimes you're not going to get it. Again, our experience is that if you've got a mediator, sometimes you're going to get more information about that.
Can I just say something about that? My interest in creating healthcare communication courses in African languages really began with a discussion with a pediatrician from Botswana. And he was describing over dinner how he asks families about their experience with a traditional healer. And he begins the discussion by saying to the mother, how is the baby's soft spot? How is the fontanelle? Knowing that this is the thing the healer focuses on as the main thing. And with that question, the discussion opens up. Whereas if you were to ask directly, what did the healer, did you go to a healer, the answer might be no. And it was that particular moment that I realized all these things we teach in communication skills in courses in America or in England, there's an equivalent series of techniques in every country, in every language, that people are discovering on their own, but aren't being taught to medical students and registrars. And I thought how wonderful it would be to incorporate that soft spot thing into a course in pediatric healthcare communication. And that's kind of how we got going.
So that would be an example if there's language specifically related to fontanelle that, from the healer's perspective, if the provider could sort of use that language.
Take that term.
Yes.
That would be
and it works. People who know how to do that, who are few and far between, are incredibly successful and have amazing stories to tell about that. If we had more time, I could tell you who they are and what they say, but it's quite amazing. It's quite remarkable.
So that might be one of the reasons why that doctor had that long line.
Yeah. Oh, absolutely.
Able to deploy that.
And he was,
language.
interestingly, and it was nothing to do with language, he was from Eastern Europe. He was a Russian doctor. He didn't have, even his English wasn't particularly good, but they loved him because he listened. And in fact, let me share this with you, and I think Neil knows the story. They did a study in Sweden, and Swedish patients were asked to judge doctors' communication skills, and a group of Swedish patients said, we like the foreign doctors better because the foreign doctors say things like, let me just check that I've understood this, because they're speaking Swedish, and then so they're actually showing sort of real interest in getting the message because of their language skills not being so good, and the patients judge them better than Swedish-speaking doctors. It's very interesting study. Yeah. Okay. Which is the point, and this is where Neil and I might have a disagreement, because Neil's working with universities, says we must put an African language into the medical curriculum. Great. My answer is, which African language, and how are we going to do this, and is this going to actually help the level of confidence both of the doctor and the patient in the situation? So we'll have that, maybe tonight we'll have that debate in the salon.
Perhaps we're doing the salon tonight.
5:30. 5:30.
Okay, so just to remind that communication is not just about getting the message across, not just about the content, but there's a huge sort of social interaction component of communication, and some of the things that are happening are not just verbal, and non-verbal issues have become extremely important in the clinic. Just seating has become, for me, a very, very important thing, and I just slightly shift seats sometimes in interactions, and you can see a huge difference happening, and these are some of the things that we've been looking at. Just to go through some of the other things, we've spoken about terminology, the fact that there's such a huge stigma attached to the term HIV/AIDS, and patients very, very rarely use it. They kind of say, she has this disease, her sickness, and huge confusion around the term positive and negative, which is really quite scary. Positive, what does that mean? Is this positive for me? Is this good? And it is not helped by kind of NGOs which say living positively, and then there's this mixed message, okay? And then huge confusion about what CD4 count means, and you just have to sit at a clinic and you just hear doctors talking and nurses talking, and they're just saying CD4, CD4. You hear the local language and you hear CD4, CD4, CD4s, and you know something's going on, but the poor patients do not know what's going on. How do we know this?
Are they given their CD4 counts, Claire?
They know they've come to have their CD4 counts, and they're often given their CD4 counts.
Do they have a small chart to track it, or
they are patient-held records. Sometimes happen in a lot of clinics because of terrible systems where files are lost and everything. So patient-held records work against all predictions.
Exactly. Never lost.
Yeah, I love that in the diabetes clinics as well. I love that, and that would obviously horrify some people.
You're not even allowed to take personal health information to your car in America. You have to be
right.
to stay in the hospital.
Okay, look at this. This is from a pediatric clinic. You don't get medicine here, only pills and that green syrup for children. Okay, they would be asking a patient, why do you come here? Well, unfortunately we don't get medicine here, just pills and CD4 cuts. How's that? How is that for an understanding of what medicine is in the life world of the patient versus our understanding of medicine? That was from the Red Cross Children's Hospital. Fantastic work. Okay, here's some examples from respiratory illness. I wanted to do more chronic, Neil said I should do all chronic diseases, but I was fixated. This was a study done by a doctor called Mike Levine at Red Cross Children's Hospital. And, he did a community-based study where he went to various informants in the community. He was trying to unpack the terminology used to describe some of the respiratory diseases in the clinic. And patients actually weren't able, parents of children weren't actually able to define is because of the difference between some of those things. And there was a discordance in meaning between what the medics were using as terminology for things like asthma, cold, fever, and minor differences for things like flu, germs, and infection. And sort of cultural explanations of illness emerging for some types of respiratory disease, but not others. So he would ask a question of a mother, what has your baby got? So the diagnosis is asthma. And she would say, I understand that there are some things floating in the air and they have got into my child's lungs. Okay, so this is her interpretation of the doctor's term asthma. And unless we merge these two terminologies and perceptions and understand what the community is meaning in terminology, we're going to be in trouble. Okay, here is a doctor saying how hard it is to prescribe pills. Okay, using an interpreter. What's difficult for me, etc. The thing is, they never do it exactly like you want them. They never interpret your words exactly like you said them, etc., etc. Especially if you have to go from English to Swana to Xhosa. It's difficult, very difficult. And unfortunately, very often, healthcare systems blame that poor interpreter or the third party. You know, if things go wrong, oh well, it's because, you know, she's not interpreting properly or she's not listening properly. No, that's not where the responsibility lies. The responsibility lies in the doctor, and you know, they're things that
the system. Well, the system.
And the system. And the system. Very much the system.
For a moment, but
okay. You defend. You defend.
We've had trouble with safety caps because push and turn is not common. And we fixed it by saying it's how you make tortillas.
That's pretty good.
Nice.
And then they get over.
How's that? That's fantastic. I'm going to put that in our armament of examples.
They would sat there and they would push and then they would turn, but they wouldn't push and turn. But when we said it's like making tortillas, they could open up.
I love that. Okay. Concepts that are difficult to understand on how ARVs work. And a lot of the protocols, and thankfully I've seen things change, but you know, there used to be in some of the NGOs which were training counsellors for clinics, they had this huge course on, you know, the picture of the HIV virus and the little soldiers and the little, you know, cells and everything. So this is this complicated, long story about the immune system. And sometimes this is not what the patients really want to hear. They're not understanding. So it's kind of these analogies and soldiers. Okay, and then these kind of things. If I forget in the morning, then I just don't give in the evening. Instead, I write it on the diary card. Okay, that happens a lot. Okay, and we did a brief sort of survey of patients in the clinic, and we said, you know, what's viral load? Only 14 out of 45 knew what it was, and these are long-term patients who've been taking medicine for a long time. It's a body part. Okay. CD4 counts. It's your kidneys. Okay. I wish counsellors, doctors, nurses and others would explain clearly how viral load is related to being positive. They should be trained properly. She thought she had a disease called CD4. Okay. That CD, my friend, I still don't have a clue what it really means. Okay, so we get a lot of that when we ask patients directly, what is CD4 count, what is viral load. We really have to be very careful about this terminology that just flows off our tongues, because the understanding is, and we need to check the understanding. Okay, you know this one. Okay, here are some other pharmacy examples, and again I can give you these articles if you're interested. We did a very detailed study of pharmacist-patient interactions in an urban clinic in Setswana, and started looking at what strategies were being deployed. And again, a humbling experience, because the pharmacists, who were primarily Afrikaans speaking, their English wasn't even very good, were speaking to were prescribing drugs to rural Setswana-speaking patients who had very little other languages. Yet these interactions appeared to be highly successful. And when we started reading the literature, especially coming from Britain, on pharmacist-patient interactions, we realized that pharmacists have a lot of trouble speaking in English to their English patients, and their patients are not understanding and everything. And yet we saw such glowing examples of good communication in this context. which made us begin to say, well, it's not just about language. It's to do with communication. It's to do with other factors, checking understanding, the use of props and things like that. So this was a very positive, I suppose, a positive finding is that, you know, where there's a will, there's a way. And we then sort of started thinking about this notion of islands of good practice. And indeed, part of my research in the last 3 or 4 years has been specifically seeking out what we call islands of good practice, where, in spite of everything, there's a line of chairs outside this doctor's clinic, or in a in Kailicha, in a terrible slum area, there's a child psychiatry clinic where all the patients come back and they get better, and you know, and this, for example. So what are those ingredients? What is that's going on there? Let's record, view, capture those elements of what actually is going on there, because maybe we can learn something from them rather than the other way. So that's what some of the research has been about. That's what we did in this study. And just a note on this. Okay, so we did 26 interactions, recorded interactions. Now, if you transcribe interactions, translate, transcribe, do all the non-verbals, etc., of 26 interactions, that keeps you busy for 3 years. So we submitted this article to a journal for publication, and we said, this is a clinic with 3,700 patients, and we did 26. And the editor, one of the reviewers said, well, why didn't you do 3,700? That's why qualitative research is difficult to get published in this area. Okay, because N is king. Okay. And I'm saying, you know, 1 is king if it's showing you something juicy, a phenomenon that we can say, all right, so let's talk. So, look how complicated. I don't have to tell you, you know this. It might be to give instructions about kind of drugs you're taking. This is a standard regimen, there's an alternative regimen, okay? And so these pharmacists, Afrikaans-speaking pharmacists, are trying to teach their Tswana-speaking patients how to take the drugs. Okay. But we were looking for this so-called organizational routine, what was happening in this pharmacy. And so we came up with this notion of islands of good practice, because we were astounded by the adherence rate, by the patients whom we followed up, you know, and asked about what they were supposed to do, their understanding of it. And so these are the kind of questions we've been asking at these sites. What is it that's going on? What's making mutual understanding happening? How do the participants co-construct meaning? What's going on in daily practice, and can we capture those and then convince others to take those on? Here's another study that I want to tell you about, which I'm just busy on it, actually finishing off. We had a 2-year engagement at a site in rural Mpumalanga. Here's some of the nearby villages. Okay, 21 doctors per 100,000 people. 92% of the population is African. Most common language is Swati. Extreme poverty. Very, very high incidence of HIV/AIDS. If you look at the most common age at death in 2007. And here we found a beacon of hope at the Legogota clinic, NGO-funded AIDS clinic, where things were happening. And patients were adherent, and teams were happy, and you know, what's going on here? So we went in with some research questions, okay, and we stayed for 2 years. This is kind of ethnography. That's my lab up top, an old container, and my research assistant Patricia, who was a local informant. She was fantastic. This is our data. This is kind of what we did. Okay. It was phased. We had to find out about the site. We did ethnographic observation. We did a lot of caregiver interviews, focus groups, and we interviewed just about all the healthcare workers there. We did an intervention workshop, and then we measured the intervention communication. I'm going to tell you about something that I'm still puzzling with, and I need your help because I just don't know what to do with this finding. Okay, well, some of the things we asked about languages, how they negotiated language differences. We asked questions: what makes communication easy? This is of all participants, not just healthcare providers, but also patients. What makes communication difficult? And my favorite question, and I always ask this everywhere, if the Minister of Health was going to come in here now, next day, what are you going to say to him? It's a lovely question. It really works. And you get all the political frustration and, you know, some of this stuff. And I just wish I could grant the Minister of Health. We used, these are our methods. Okay. Now, this is the secret to this clinic. This is exactly the secret to this clinic. Somebody in their wisdom built a lovely deck, which is kind of in the center of the clinic, and they serve tea on this corner, and the staff and the patients both go there for tea. And there's this mingling, which is absolutely lovely. So this is in an informal structure. Nobody ever said this is to improve communication. Okay, but it's working. And I was so excited. And, you know, I said, oh, this is wonderful. And then 6 months later I went back. They built a sort of a barrier because the staff said the patients are stealing our sugar. Okay. Then there's another intervention at this clinic. I'd been to Paul Farmer's clinic in Rwanda, and I was extremely excited about the vegetable gardening and his theory about food security, etc. I said, okay, now we're going to plant vegetables. And I went to this clinic. I said, look at this beautiful area. You've got rich ground. Look at your soil. This is fantastic. We should start a vegetable garden for the patients. Yeah, I felt very, very effective. Came back 2 months later, and they were digging up a whole area behind the building. I was so excited. I think this is why I stay in Africa. This is me. I'm so relevant. It's fantastic. We're going to have a full farmer clinic here any minute. I said, what's going on here? They said, we're making a soccer pitch for the staff. So that's humility.
Exactly.
Okay. But here is this magic thing that's happening at this clinic. Under the deck, the patients are waiting kind of for their initial appointments and their vital signs and everything. But there's a guy who sits there. He's an expert patient. He's a guy who has received treatment at the clinic, and he's paid very, very little. He's got a wonderful personality. And he runs a kind of an informal group. He's an informal counsellor. And they're mostly female patients. We know about the demography of the disease. And what happens is that patients actually get drawn to him. He's a showman. He always has something to say. They bring their plastic chairs, they go in and they go out, and there are these conversations that are going on. I became absolutely mesmerized by the power of this process. Now remember, this clinic does employ formal counsellors who are sitting in little rooms in the clinic and everything. But this guy was doing something very, very magic. And when in my interviews, the patients were telling me, you know, we love this group. This is why we come to the clinic. Whereas some of the health professionals are saying, well, we know that this group happens, but we're a bit suspicious, and we think sometimes he tells the wrong things to our patients, etc. So there was maybe a level of suspicion about what was going on underneath there. So I got permission to audio record, and I interviewed him. He's just such a lovely guy, and I hope he's still alive because he was very ill. Here are some of my lovely people, and these are my notes. Just this is an ethnography. So this is saying this is what's happening. Who's in the group? What's happening? There's noise, interruption, blah blah blah. Okay, getting very excited. I love ethnography. Okay, Please record 3 group sessions, etc. What I wanted to know is what was going on there. And I started looking specifically linguistically at some of the things that were happening. A lot of code switching between English and Siswati, very interesting. Remember, these are all Siswati-speaking people. But he's giving a message about HIV, which is kind of in code switching, which I think is very useful. Okay. There are lots of interruptions. It's very informal. It's not somebody sitting in a nice circle. Okay. There are people coming and going. There are chickens. There are babies crying. He stops his tirade about ARVs and he'll greet somebody walking past. And there's a lovely informality. And he uses a lot of lovely performance features which are linked to his style. I don't know what, charisma, I don't know what we're looking at, but we're looking at a special individual. Okay. And this is what he does. He exemplifies, he concretizes, he explains, he dispels fears, he demonstrates, he does all sorts of things. But what for me was wonderful is that the people attending that group felt very free to talk. So I said, what are they talking about? Here. What are they asking him? And I love this. Why do I love this? Because it doesn't appear in any other doctor-patient interactions that I have been looking at, where a patient, where the doctor says, any more questions, or do you have questions, or do you have some questions, however you're going to phrase it, whatever you're told to do, does not elicit usually these kind of questions. But these are the questions that are going to come out in that informal space. Is it bad to take Coke? That's not our sort of Coke. This is Coca-Cola, guys. Okay. All right. Is it okay to take too much peri-peri? Is it okay to have sex without a condom? Is eating garlic prohibited if I'm positive? How do I tell my new boyfriend about my status? Very important for me is kind of the disclosure issues, which never, ever really come up in formal interactions. So I was very excited when these questions came out.
I have a quick question. Does he get any training from the clinic?
Does he get any training? Some, but he's actually taken it upon himself to develop his own style and do his own thing. And sometimes he gets a pharmacy assistant to come and help about the new drugs, these generic drugs. This month you're taking this yellow pill. Last month, you remember that red pill? Now this month it's this yellow pill. It's such a pain. But anyway, okay. Let's see what they say. Okay, this is a patient. Okay, when I meet any person, I do not care about using a condom. We just had sex. That's just for fun, yes. But when coming here, I heard it's not right. Yeah, we just have sex, you see. When having sex, you have to use a condom. I took that point, I used it, and so on. But this is what I like. Because I did not know, and I was not free. I did not feel free even to test or what to do. But when sitting at the support group, they teach us. I can see that it was important because you can be protected, you can have a long life, etc. Support group, which has opened my eyes, nothing more. What I did not know, it taught me. So some really nice confirming opinions in the interviews about the power of the support groups to change behavior. Running out of time. Okay.
We do have the room booked for another half an hour after.
Okay, well, we're nearly getting there. Okay. Okay, so here's what I want to, here's my paradox. I recognize that the value of that support group is its informality, that it's actually working because it's not a clinic structure, it's not in the system, it's kind of an add-on to the system. So I would be very cautious, and I actually haven't finalized the report because I don't want to elevate this group to a formal structure because I'm scared it's going to lose its very qualities. At the moment, that person, our expert patient, is facilitating in a particular way without a set of rules and frameworks which is actually working. Elevating the importance of what he's doing within an existing structure may very well create tensions for the paid counsellors, the NGO-trained counsellors. They're following a particular route, and it might cause some things that I don't want to happen in terms of the patient's good. So this is my dilemma at the moment. I mean, what is, you know, how do we deal with these superb examples of good practice without actually turning them into bad practice by formalizing them? I don't know what I'm saying. Do you know what I'm saying? Okay. How do we know turning it into practice? How do we know? Here's my other dilemma. Okay. How do we know if it's effective? How do we measure? We can't. Is it just interview material? I mean, I had this discussion with Neil yesterday. How do we know if an intervention is working? Because so many other things happen in an intervention or result from an intervention which may not be specifically due to communication training, for example. So, but these are some of the principles that I'm trying to put into any interventions that I'm doing, learning from islands of good practice, not coming, you know, the least helpful is probably going to be some of the existing textbooks on intercultural communication. That's really going to be the least helpful because they're sort of list-driven and they just don't work. Okay. I also do believe in this principle that an intervention should be site-specific. So what works in a diabetes clinic in Johannesburg is not going to work in a diabetes clinic in Mpumalanga, and there's some good reasons for that. And I insist on a team rather than a profession-specific intervention. So a doctor will say, oh good, you must come and talk to our nurses about communication at our clinic next time you come, and say, forget it. I want you all in the same room together, and we're all going to do this together. And this is something I know that Neil speaks about a lot. And then sort of, rather than ignoring contextual factors like poverty, stigma, etc., you need to have all 4 feet in the trough. You need to get into that and kind of understand that, and that's where we need the help of some social scientists. So here are some intervention projects that we've done, and I think we're running out of time. We've done some nice work on informed consent and actually modifying informed consent. I spoke a bit about that last night. We did a lovely long-term engagement at Proteskier Hospital in the pediatric AIDS clinic where we did individual communication training for counsellors in a clinic, and we were able to effect change in some dimensions for some counsellors, and that's a very important message. It's not a one-size-fits-all, and some people just shouldn't be in a situation where they are communicating with people. End of story. And we need to choose those. We need to know that before we appoint them, basically. And then Neil and I, we can talk a lot about some of the methods that we feel might help. One of the things I'm really excited about is the drama project. We did a drama intervention at the ACTS clinic for healthcare professionals, and we took really tricky issues like disclosure and adolescent sexuality and things like that, and we trained medical teams, doctors, pharmacists, everybody in some of these things. And we've also used one of my master's students actually is a drama student, and we've been using this with patients as well to empower people in communication, and it's worked very well. So that's more or less it. I've got a couple of nice slides at the end, but I think that's it formally and very open to discussion and commentary.
Thank you.